Muy buenas tardes, bienvenidos al blog del doctor Máximo Gómez Nacer. Voy a hablarles sobre presentaciones comunes en la vida real y en los exámenes del board de los Estados Unidos y cómo se pueden pasar estos exámenes teniendo en cuenta informaciones que ellos quieren que nosotros sabemos. ¿Okay? Ahora, con la ayuda de medios audiovisuales, a lo mejor podemos facilitar esta comprensión. Quiero ver cómo sale. Vamos allá. Empezamos con un niño de 7 años que viene con una lesión maculopapular. So the first case is a 7-year-old children that comes with maculopapular rash. Now we stop right there. That is the headline of the question, and we go immediately and we see what they want. If they want to ask for treatment, they want to ask for diagnosis, they want to ask for management, usually they ask what is the next step in the process. In order to know what is the next step, we browse through the choices. The choices can be, for example, as life-threatening as produce immediate intubation, which is, for example, understanding that you read the clinical picture, and for that particular picture, you have decided to immediately take emergent steps. Or it can be something like, what is the next, what is the diagnosis, or what is the virus? So let's talk about the exanthematic disease of the children. We can start with the basic measles, mumps, rubella, and Roseella infantum. These are very common in the United States, well, basically because they coming is a place where many immigrants come, and many children do not have the proper vaccination. So it's not something that we can say is completely forgotten. We have to forget. No, we can still see the measles, the mumps, the rubella, all the disease. How is the measles? For the purpose of the exam, usually we have to understand simple keywords. Whenever we see the 3 C's, like cough, coryza, and conjunctivitis, usually they are talking about the measles. We have to know the prodromic word Koplik spot, Koplik, K-O-P-L-I-C, Koplik spots. They are very small, round, circular, multiple lesions inside the mucosa. Whenever we have that, is a prodromic for getting into the disease. Actually, when you have that, we can actually get a title for immunoglobulin of the body, and we can get the diagnosis of a early stage measles. Or we can even get a smear and see the giant cells that are identify this disease in the as a diagnosis test. Now, let me show you how this works for the purpose of understanding. So here is a presentation. Let's go and start with the typical cases, how this looks. The measles usually starts in the head and spreads to the trunk, to the body. It produces a sort of maculopapular rash. Okay, now this is some of the lesion. The lesion creates also involvement in the hands and in the feet. So it helps us, it's one of those conditions together with the Coxsackie virus that can involve the hands and the feet as a part of a maculopapular rash involvement. Now, the clinical diagnosis, usually we can get the smear, get that giant cells. Usually we don't do that. We just do it clinically. As soon as we see the children developing fever, maculopapular rash, cough, coryza, conjunctivitis, involvement of the hands, bingo, you have a diagnosis. This is what they want us to know. Now, let's go another maculopapular rash that is very similar, and this is the rubella or German measles. Usually have a less extent of involvement in times of days. However, it's also very common because this is the way the children will appear. It will come with something like this. The involvement is very pronounced. It can be in the face, and from there it spreads to the rest of the body. This is how the children would look like with the rubella, with the German measles. Maculopapular rash, and something very important is that these kids usually do have lymph node involvement. So it's posterior cervical lymph node involvement. is something that these children can have. And also, as a clinical feature of complications, these children can develop these opacities in the crystalline. Okay, so it's something, if you see this picture and they ask you, what is the disease? The disease was rubella inducing these cataracts. Okay, now what else do we have? We have the Rosola infantum. The Rosola infantum also is called exanthema subitum, and it is a disease that starts first with a fever, and suddenly out of the blue it starts with a huge spread of maculopapular rash all around. So this is Rosola infantum. It has a rosy appearance. That's why they call roseola, because it's kind of red. This is a posterior trunk, how this is completely spreading. Look at more detail. But please notice that all the lesions are virtually in the same stage. So there is no change. It's also the same stage, look huge, but it's simply, the kids actually are very fine. It's just a viral infection that will go away in approximately 7 weeks. Now this is a kid who had roseola infantum. Look himself, he's like Curious George, discovering himself, discovering his stuff. Look at this. He is ready to go home virtually. By just looking at him, you realize that he's really a fine kid there. Now let's go with the mumps. The mumps, actually the name is parotiditis. This is in swallowing, in inflammation of the salivatory glands. We have the parotids, we have the sublingual and submandibular gland. So not only involves the parotid, so it's not only the parotiditis, but it can also involve all of them and produce big swallow. And not only that, and it can also produce complications, because it's right there. It can create thyroiditis, right there, the thyroid gland. It can go neuritis. It can go to the brain. It can go to the heart and produce carditis. It can go to the pancreas and produce pancreatitis. So those are the features. The mumps can even go to the gonads and produce orchitis. And this orchitis is serious because it can leave the person sterile for the boys. So it's something very serious. We can detect it by measuring immunoglobulin G and M titles. We usually don't know that, because once you see this face, it's very likely that you will never forget. So it's just simply a simple parotiditis or mumps, I would say. Something important, that since this is how the children will look, they are feeling with the malaise, they are obviously can have a fever. This is a young adult, how this young adult would look like. The involvement can be systemic, but again, the reason that we have virtually none of this is because we have the MMR, measles, mumps, and rubella vaccination that we provide approximately the age of 1 year, and then we can continue to provide. So since we have the vaccinations, most of these conditions have not been so frequent, but still we need to know about them. Now this is another disease. This is the, well, it's talking about the next exanthematous maculopapular rash. This is the typical case that I started describing at the beginning, which is a children that come with maculopapular also develop some very pruritic lesion that develops vesicles and cross. This is called chickenpox or varicella, produced by the varicella virus. It's a viral infection that is going to involve many parts of our body. Of course, it's going to just create these lesions and highly contagious. Now, for the purpose of this exam, when we see the children in real life, we just see the person, we know what the person has. But for this exam, you don't know what they want to ask you. So you have to go and you see the red line. Children will come, maculopapular rash in vesicles, boom, you already know what is vesicles, cross. This is varicella, chickenpox. But now you have to know what they ask. So you go immediately and check what is the next step. And the next step, it can be anything, because probably they want to test if you know what are the frequent complications of a chickenpox. And you have to know that it can produce meningitis, or it can produce inflammation of the lungs, it can actually produce ataxia, or it can produce this basically residual infection of the nerve, because this virus goes into the nerve and it stays there forever. And at some point can come as a neuralgia, trigeminal neuralgia. It will come with all the face, and it's basically secondary to the varicella that the children already had. Now, some of the classical complication is called the Guillain-Barré syndrome. It's an ascending palsy. The person starts feeling weakness in the lower extremities and can come all the way to the lungs, and the person will have a serious palsy that involves accessory muscles of respiration. So in those cases, when it's very severe, and they ask you, what is the next step? They know that you identify the disease. They know that you know a lot about the disease, but they want you to know that next step is you can probably need to intubate the patient because you recognize there was a complication. And it was called, in this case, by Guillain-Barré. Okay? Well, whatever is the next procedure. Let me see and show you some of the pictures. This is the typical varicella. The varicella usually comes with different stages of macular, papular, vesicles, and cross. As you can see, let me show closer. So you have this, seems to be macular, mostly more of them, but these are vesicles. So vesicles are defined by the presence of liquid inside. And the papular would be something like this, that it seems to be solid. So it doesn't have liquid. But now when we have the vesicles, it's highly contagious because those vesicles get spread, broken, the liquid goes out, and it contaminates the whole neighborhood. Basically, this is how it goes. So if the next step, what is the next step? It can be something like this, or it can be, they show you something like this. So look at this. This kid seems to have already something, seems to be a crust. So it's healing. But they are not 100%. Those seems to be healing, meaning they are okay, but you still have to make sure that it doesn't have this, which are vesicles. This vesicle will be contagious. If all the lesions are healing, the kid is ready to go home. So if they ask, what is the next step? Probably the choice is send the kid back to school. Probably that's what they want. That's the question. So it's just a knowledge of how these exams prepare these questions. By the way, this is a children that has involvement in something that seems to have like a vesicle, which is involving in the hands. This is also a virus. There will be a differential diagnosis for hands, foot, mouth disease, which is produced not by varicella virus, but by Coxsackie virus. Okay, look at how it looks. Okay, so basically, how is the treatment? We have to understand, in the varicella, sometimes they can ask you if you're going, let's say one typical case, can be a sexually transmitted disease. The mother acquires the disease in the 5 days before the delivery, or in the 2 days after the delivery. So the mother didn't have time to develop antibodies. This children comes, and when it comes to the birth canal, it gets exposed to these lesions, and the children, guess what? Develops varicella. The question is, when you see this in the mother, what is the next step? And the question, what they want us to do is to immediately recognize their reality, that it becomes like a sexual transmitted disease, and therefore, by the own mother couldn't transfer the antibodies, and you have to provide the antibodies, because the mother couldn't have time to produce her own immunity and pass it to the baby. Now, in that case, what is the medication? It's called IgV, varicella zoster immunoglobulin. That's the medication. So we have to actually provide passive immunity, just giving the antibody, that provide the protection for these kids from developing any of those complications later on. Okay, so this is one of the typical cases. Now, it can also, we saw encephalitis, it can be ataxia, it can go Guillain-Barré, it can be some of these complications. Now, what happens when you see a children like this? Look at this face. It's something completely different. We have, in this case, something that is more spread. This is not a virus. This is an infection. This is an infection that produces a epidermal, the most superficial part of the skin, which is the epidermis, get infected. This is called impetigo. Now, whenever we have this impetigo, this is a bacteria. This is a Staph aureus, or it can be, sometimes they have a component of beta hemolytic strep, Streptococcus beta hemolytic. This is a serious bacterial infection because it is the type that can go to the heart, produce some autoimmune disease, and produce some valve disease, some heart valve disease, some mitral stenosis disease, something serious. So we still superficially get. When they ask you these keywords, honeycomb lesions, whenever you see this, honeycomb lesion is this. It's something that looks like this or looks like this. This is impetigo, and this is a superficial skin lesion produced by this bacterial infection. Something important that we have to understand. Now, what we have here is something different. Okay, in this case, we have basically it's a skin lesion also, but note what is mostly in one side of the face. It doesn't affect the other side, it's only in this side of the face. And when we continue to explore, we can have also the same, a skin lesion that doesn't breach, and therefore is a skin lesion that most likely is very painful. This is also the herpes, not the herpes from the chickenpox herpes virus, but herpes zoster. Now, the herpes zoster is painful. So if you want to know what is the hallmark of the varicella, it will be the pruritus. That's why we have to use the calamine zinc lotion to decrease the pruritic sensation. But this is different. This is very painful. And this is a similar family of virus. This is how it goes into the oral mucosa. What kind of lesion it produces? Look at this. This is called, by the way, gingivostomatitis, herpetic gingivostomatitis. Whenever you see this, or we can have this too. Again, this is produced by the virus that is living in the nerve and is at some point like bursts into the skin and produces this lesion only in one side of the body, and it's very painful. You don't see that into the other side, it's just that part. That's how we make the differentiation for the treatment. Now look at this. When we look at the mouth, we saw something like this, and this is called herpangina. Herpangina. Now, do not confuse it. It's a misnomer. It's not herpes. It's not this. This is oral mucosa, anterior part of the mouth. This is posterior part of the mouth, and it involves the soft palate. So it goes back to this back, and it's both sides. This is called herpangina, but it's produced by Coxsackie virus. So that's how the boards can ask us. This is herpangina. Tell me what is the viral infection, and you go, oh, herpangina is herpes, da. Oh, no, it's not herpes, it's Coxsackie. Okay, so basically something important. This is a Coxsackie virus, and now this is another one that can show you. Look at the skin lesion, the oral mucosa. This is Coxsackie infection again, and now it goes with the differential diagnosis: virus versus infection. We're going to have hundreds, thousands of cases coming like this, and sometimes the family is stressed. Do we have to give the antibiotic? Is it necessary? Is it absolutely necessary to give the antibiotic? Well, depending. Let's see what happened. So we look at the mouth of the children, and we look what happened. If there is a involvement of the uvula, that is 100% sure is going to be a bacterial infection. So right then you don't have to just even worry. Just provide the antibiotic. If it has a swallow amygdala, these are the amygdalas, by the way. If the amygdalas are swallowed, it can be virus or bacteria. But if it has a patchy, thick secretion, like this, patchy, thick in secretions, either white or red, any patchy infiltration, thick, that is a bacterial. versus compare the virus infection. It doesn't have, it's not so patchy, and however, it doesn't involve the uvula. That is the distinctive feature. This is how we differentiate. Okay, so basically, let's go back. This one I was taken from the internet, from Medscape.com. They say this is a Streptococcus pharyngitis. So this is a bacteria. However, it doesn't have the thick plaque, the thick exudate. Apparently, because it doesn't show the uvula. Apparently, it involves the uvula, and this is how they diagnose that. Now, this is another one that again is bilateral, and it spares the uvula. It doesn't touch it. Therefore, but actually the exudates. Don't look at the tongue. The tongue in this case is seborrheical tongue, but this is not what we are looking for. We are looking for this erythematous base in the oral palate, and these are the ones that tells us this is a Coxsackie virus. Okay, so basically this is another, what is the presentation. This is go now to another exanthematous disease frequently in these children. Okay, and now in this case it's going to be the slap cheek syndrome, something that sometimes looks like children or child abuse. It's a parvovirus B19 and is very contagious. Okay, so there, this is the erythema infectiosum. That is the name. This is how this looks. Erythema infectiosum. The most important feature when we see this, we know it's a virus. However, we have to make sure that the patient doesn't have hemolytic anemia, some sort of autoimmune anemia produced by this virus that has been associated with it. This is how it looks. The children can be irritable, and this slap cheek is bilateral. And the patient, look at this beautiful, lovely girl. She has normal, she's sad, obviously she's feeling sick with the virus, but it's not child abuse, okay? This is just a slap cheeks for the appearance of the infection. This is another very happy camper, beautiful, lovely girl, slap cheek syndrome, parvovirus B19, erythema infectiosum. Don't worry. This is, oh, this is my body here. He's like having fun in the beach. Look at that. He is so happy, so relaxed. Is recovering 100% right there, as you can see. So this can have one of those slap cheek syndrome infections. Now let's go to another infection. In this case is also an exanthematous disease. It produces a maculo-papular rash, but this is in older children. And this is called the Epstein-Barr viruses, also called infectious mononucleosis or the Keys disease. Now, what happened with this? This is a disease that we have to identify basically because of the presence of lymph node involvement. The kids come with this big lymph nodes involvement right there. Pre-auricular, basically it produces heavily in the oropharynx. It produces big swallow amygdalas, and it produces a lot of secretions. Now, it's a lot of a problem because that's not all. It can produce photophobia, it can produce involvement in the stomach, it can the nausea, it can have the hepatosplenomegaly, a huge spleen, and it's so huge and grows so big. So these are the kids that we actually have to. Next step, if they ask you what is the next step, put the kid horizontally and explore the abdomen, but very tender. Don't press it too hard because you can break the spleen. That's how sensitive they are. And also, basically, just palpate softly from the borders up carefully. And also, if this kid is like bumping into a furniture or something, these kids actually can have a spleen rupture. So those are this kind of this condition. Epstein-Barr virus, totally different. It's a infectious mononucleosis called the Keys disease. Now these are the symptoms, how they are spread all around. Again, these are how they explain. This is a picture that shows even right in behind. You see this prominence here? That prominence is a lymph node. That is the involvement. That's how big it is. You don't even need to touch it. You can even see it. this is how serious it is. You can just, by looking at the kid, and you sometimes just imagine what is the disease. This is a teenager, basically, and you can see, by you look at the mouse, this is what you see. Basically, it has involvement in the amygdala, how enlarged they are, and this has a thick exudate here, a white thick exudate, erythematous, which is reddish base in the oropharynx. And another one here is also the same. Look at this, oropharynx involvement, and they have the thick coating. That's what they call the thick exudate or coating. That's basically, this is taken from the internet courtesy of the gentleman that had the, produced a picture there. So the internet picture, Epstein-Barr virus, this is how thick, how severe they can look there. Internet picture, how they look at how this is severe from Epstein-Barr virus, infectious mononucleosis. Look, the exudate, the amygdala, the whole clinical picture. This is a folliculitis. Basically, you get by the picture, it's not a small baby. This is a grown young adult at this stage now. You can see this is the maculopapular rash that we have. So we're looking at a maculopapular rash that can spread, especially in the back. Look at this, how spread it is. It can have a fever, of course, general malaise. Now, we can do the diagnosis by looking at the peripheral smear. This is a normal lymphocyte. This is what is called the white blood cells, okay? These are the red blood cells. This is the MAT, that carries the blood. This is the one that protects us, give us immunity. Now, when you have infectious mononucleosis, this is how they look. They got super big. So big mononucleosis is a big mononucleus, big is lymphocytes that is pathologic. From a pathology, basically this is how the lymphocytes look, very big, for this infectious mononucleosis, Epstein-Barr virus. Now, okay, what is the treatment? Prophylaxis. This is how they get the disease. So guess what? If you want to do prophylaxis, the prophylaxis will be no kissing. Okay, basically that's a prophylaxis. No kissing with these kids when they have some of this obvious lymph node involvement. They can have a Epstein-Barr virus, and is very contagious. So the treatment in general, it has a treatment. We can give it treatment, antibiotics. The ampicillin is the treatment. We have the ampicillin. By the way, when you have a person like this, what is the next step? Bring it to me, or bring it to your doctor. Bring it to the doctor, please. Don't kiss that person. Just make sure that you don't have a sexually transmitted disease, which is disclassified as that. This is the ampicillin and amoxicillin, basically. Some people can give augmentin. Augmentin would be the ampicillin combined with the clavulanic acid. Well, ampicillin and amoxicillin just would be fine. And so basically this is in general some of the general features for viral infections in the children that are common, and the differential and how we can see that frequently. In the next presentation, I'm going to bring some other skin lesions, including lesions that are very common in the United States, produced by insects, like tick bites and things like that, and how we can differentiate. Some of them can be life-threatening. So I hope you welcome back again and see the series, the blogs of Dr. Maximo Gomez-Nacer to your service, and have a wonderful and blessed evening. Thank you very much for watching.